Evening all. Welcome everybody for the PG case presentation on Genitourinary Radiology in association with JournoMed. And for this session, I welcome Dr. Gomadi Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. And as you know, actually on Wednesdays, we are doing case presentation. And on Saturdays, actually faculty presentations. And in case presentations, we almost cover almost all the cases, all the typical cases. And in January, we covered chest cases, and in February, cardiac cases, and then in March, hepatobiliary, and then GAT in April. And now we are moving on to genitourinary. And today being the first day, so here, the one who actually who can view all the or who can see all the presentations now in the 4 weeks time. So most of the cases you will come to know that most of the cases will be covered in that 4 weeks time. And also in the during Saturdays, no faculty series, most of the topics will be covered in the particular session. Most of the topics will be covered. So like that, actually we are planning. And today the genitourinary, our faculty is Dr. Arif Khan Sainuddin, and he is associate professor from the Sri Mugambika Institute of Medical Sciences, Nagarkovil. And on behalf of IRIA Kerala and on behalf of myself, hearty welcome Dr. Arif Khan Sainuddin.
Thank you, sir.
And also today the program is coordinated by Dr. Reshmi. She is consultant radiologist in Anandaburi Hospital and GG Hospital. And I welcome Dr. Reshmi for this session. And once again, I welcome all of you for the session. Now I am passing on to Dr. Gomadi Subramaniam, President Kerala IRIA.
Hello, all of you. As Dr. Venu said, we have Kerala IRIA is doing their best for the resident teaching program. And as he said, we have covered most of the topics and we have entered into the genitourinary system. Today is the first stop. So all the residents, please be online and listen talk because it will be so useful for you for the examination. You become more bold when you see a lot of cases. Over to you, Dr. Reshmi. Unmute, Reshmi.
Okay. Thank you, Gomadi ma'am, and thank you, Venu sir. So welcome back to our academic session, which is organized by Kerala IRI. So this month we are starting genitourinary radiology after being covered chest, CVS, and GIT. So today we have the first case presentation by a resident, Dr. Nisha from Sri Mugambika Institute of Medical Science, Kulashekaram, and we have as faculty Dr. Arif Khan Sainuddin. So it's my pleasure to introduce Dr. Arif Khan Sainuddin. He is currently the associated professor in Sri Mugambika Institute of Medical Science. He completed his MBBS from MES Medical College and MD Radiodiagnosis from AJ Institute of Medical Sciences. And he's mainly interested in oncoimaging and diagnostic interventions. And he is interested in traveling, vlogging, and he has a YouTube channel for radiologist training the interventionist. And he also conducts regular discussion sessions in Instagram as well. So he's a new generation radiologist and he's highly interested in academics. And apart from radiology, he's a big fan of Marvel Universe and Matthew Rayleigh. So over to you, Dr. Arif and Dr. Nisha. So we'll start the session on genitourinary radiology. Over to you, Arif, and over to you, Nisha. Okay.
Okay, thank you, madam and sir, for your wonderful words. And this is my, I think, second stint with IRA. We had conducted a quiz a little bit back. And I think I will hand it over to Jennifer because it's already time. We will start the session.
I think we also have some spotters also at the end, right? After
yes. Stay tuned. We have 10 good spotters.
Yeah.
It will be helpful for us.
That will be very useful for the residents. So all of you, please be online. Okay.
Isha, please share your screen and
Okay,
start.
sir. Thank you, ma'am. Thank you, sir. Good evening. I'm Dr. Nisha Jennifer, second year radiology resident from Sri Mookambika Institute of Medical Sciences. Today, I'll be discussing a case on GUT. A 48-year-old female came to Department of Radio Diagnosis with complaints of abnormal uterine bleeding and anemia. We did her an ultrasound abdomen and pelvis, shows bulky uterus with multiple small intramural fibroids of varying sizes and a large submucosal fibroid. Incidentally, we had a finding of a solid hypoechoic mass lesion, predominantly in the interpolar region of left kidney. We did color Doppler, it shows central vascularity. Then we subjected the patient to contrast enhanced CT under renal protocol. Non-contrast image shows a well-defined isodense with focal hypodense area involving the upper and mid pole of left kidney. There is no evidence of calcification, hemorrhage, or fat within the lesion. We did contrast study. In contrast study, in corticomedullary phase shows a hypoenhancing lesion when compared with the enhancing renal cortex. The syncal left renal artery appears normal. In nephrographic phase, the lesion is hypoenhancing compared to the enhancing renal parenchyma. The lesion is superiorly abutting the tail of pancreas and lower pole of spleen. Laterally, the lesion is abutting the descending colon, but there is no gross infiltration. Renal vein appears normal. In excretory phase, the lesion demonstrates washout of the contrast. The upper and mid calyxes appears effaced by the lesion. In corticomedullary phase, the lesion is hypoenhancing as compared with the enhancing renal cortex. This is nephrographic phase. The lesion is hypoenhancing as compared with the enhancing renal medulla. This is the delayed phase. We are able to demonstrate washout of the contrast. While right kidney appears normal, IVC appears normal, adrenals appears normal, visualized lower chest appears normal, visualized spine appears normal, and there is no significant retroperitoneal lymphadenopathy. CT pelvis revealed uterus is enlarged in size with an enhancing submucosal fibroid. To summarize, the large, well-defined, homogeneously enhancing lesion involving the upper and mid pole of left kidney, which is superiorly abutting the tail of pancreas and lower pole of spleen. Laterally, it is abutting the descending colon, but there is no gross infiltration. The lesion is causing mild effacement of upper and mid calyxes. The renal hilum appears normal. The renal artery, renal vein, IVC appears normal. We gave a nephromatic scoring of 10x, which indicates like high complexity. And we arrived at a Tnm staging of Tn1B N0 MS, which indicates stage 1. Patient underwent radical nephrectomy. Biopsy report came out as oncocytic papillary renal cell carcinoma, ureter, renal sinus, pelvic callus, renal hilar vessel, hilar fat appears normal. Pathologic staging came out as T1B, NX, MX. Renal cell carcinoma is otherwise known as hypernephroma or Gravet's tumor. It's a primary malignant adenocarcinoma arising from renal tubular epithelium. Most common malignant renal tumor. There are several types of renal cell carcinoma. It's clear cell renal carcinoma, which is most common, seen in 70 to 80% cases. Papillary renal cell carcinoma, clear cell papillary renal cell carcinoma, chromophobe renal cell carcinoma, which is seen in 5% of cases. Collecting duct renal cell carcinoma, this in Bellini duct, it is seen in less than 1% of cases, which have a very worse prognosis. Renal medullary carcinoma, sarcomatoid renal cell carcinoma. Almost 2% of RCC or bilateral, 60 to 25% RCC or multicentric in the same kidney. Usually RCC or hypervascular, except papillary carcinoma, which is our case, which is hypovascular. It can have some areas of fat within it. If there is combination of fat and calcification, it suggests renal cell carcinoma. Calcification is not present in renal angiomyoma. It has only fat. It has macroscopic fat. If there is chance of 23% chance for extension of tumor into renal vein, 7% extension into inferior vena cava. Metastasis from talking from most to least common, lung is the most common site to be involved, followed by liver, bone, adrenal, then comes the opposite kidney and brain. There is an entity known as cystic renal cell carcinoma. Enhancing smooth and or not, it has an enhancing smooth or nodular septa. Talking about the CT techniques which was used in renal protocol, the baseline is non-contrast CT. This non-contrast CT provides a baseline information about the enhancement of the lesion. So this baseline enhancement is comparable when we are giving after administration of the contrast. It is important in distinguishing a hyperdense cyst from a solid tumor. If there is an enhancement value of plus 12 ounce field unit, it is almost considered suspicious for malignancy. And most of the renal cell carcinoma will have an attenuation value of plus 20 ounce field unit, or it can be even greater than that. And calcification can be seen in 30% cases of renal cell carcinoma. We are contrast CT. We are using an intravenous contrast material, 120 ml biohexor. We are injecting at a rate of 3 ml per second. The first phase is, we have 3 phases in this. First is the corticomedulary phase. Next is the nephrographic phase. And third is the excretory phase. The first phase is the corticomedullary phase. It occurs 25 to 70 seconds after the start of injection. In this phase, the contrast primarily fills the cortical capillary, peritubular space, and cortical tubular lamina. In this phase, the renal cortex enhances brightly than the medulla. So the cortex will enhance more and medulla will be minimally enhancing. The disadvantage of this phase is a small hypervascular renal cell carcinoma may enhance to the same degree as the renal cortex. So we can mistake that for a normal parenchyma at corticomedullary phase. We have two like false negative and false positive. The false negative occurs when a centrally located tumor is we are mistaking it for a hypoactinitic medulla. And false positive is like mistaking an enhancing medulla for a solid tumor. In negative, we are mistaking a hypoactinating tumor which is in medulla for a normal. And in false positive, we are mistaking an enhancing medulla for a solid tumor. This phase has some advantage. The main advantage is maximal opacification of renal artery and vein occurs. This allows confident diagnosis for the extension of the tumoral tissue and gives a perfect anatomy of arterial anatomy. So it helps in selecting patient for nephron sparing surgery. And metastasis from renal cell carcinoma are hypervascular. So it usually have a rapid enhancement during this phase. The next phase is a nephrographic phase. In this phase starts 80 seconds and lasts up to 180 seconds from the start of the contrast. This phase begins when the contrast material fills into the glomerulate. This collecting ducts are filled up. It ends loop of Henle and the collecting tubules. The renal parenchyma here enhances homogeneously. Both the cortex and medulla will enhance homogeneously. So it allows a better distribution of renal masses. So enhancement of solid renal tumor is greater during the nephrographic phase than during the corticomedullary phase. So nephrographic phase is the most valuable phase for detecting renal masses. Excretory phase. This phase begins 180 seconds after injection of coordinated contrast material. In this, the contrast is excreted into the collecting system, so the attenuation of nephrogram gradually decreases. This helps to locate a this helps in location of a centrally located mass which is in the collecting system, and it defines the involvement of calyxes and renal pelvis. In this image, in a unenhanced CT shows a isoattenuating lesion with a isoattenuating mass with a contour bulge. This is a contrast intract CT. This is a corticomedullary phase. This is hypoattenuating. The mass is hypoattenuating compared with the enhancing renal cortex. We are able to see that cortex is enhancing and medulla is hypoenhancing. This is nephrographic phase. We are able to see a hypervascular mass, which is we are able to distinguish a hypervascular mass from an enhancing renal parenchyma. In this phase, both cortex and medulla will enhance homogeneously. So it helps to differentiate a hypervascular mass from an enhancing renal parenchyma. The differential diagnosis of renal oncocytoma. It is usually enhancing. There is enhancing mass that is usually indistinguishable from RCC. In 30% or 1/3 of cases, we can see a hyperattenuating scar and may or may not have a stellate lesion. The next is renal angiomyelipoma. This is an intratumoral fat-containing mass without any calcification. If there is any calcification, it comes under renal cell carcinoma. If the 5% of renal angiomyelipoma, it have minimal or no fat. It's an entity known as most lipid poor angiomyelipoma. These are hyperattenuating and homogeneously enhancing. Transitional cell carcinoma of kidney. This causes the renal infiltration, so kidney is enlarged, and but the shape of the kidney will not change. The shape will be maintained. The bean shape of the kidney will be maintained, but there will be poorly defined margins. The renal pelvic defect and irregular narrowing of the collecting system will be there. It causes the pelvic caudal system enhancing, and it is an hypovascular tumor. Renal metastasis and lymphoma. The most common site for metastasis is from lung, then the breast, colon cancer, and melanoma. Usually, it's a hypervascular tumor with infiltrative and cavern exophageal growth. Lymphoma, it can be multiple or bilateral. It have an infiltrative growth. It is an also hypoechoic. Metastasis and lymphoma are hypovascular. Lymphoma is hypoechoic, hypovascular, solitary, and intrarenal mass. It can or may not have adenopathy, which resembles like renal cell carcinoma. Tnm staging. First, we are talking about T, that is Tx, the primary tumor cannot be assessed. T0, there is no evidence of a primary tumor. T1, the tumor is in T1, the dimension, the greatest dimension of the tumor is less than 7 centimeter, and it is limited to kidney. In that comes two, that is T1A and T1B. In T1A, the tumor is less than 4 centimeter in greater dimension, and it is limited to kidney. In T1B, the tumor is more than 4 centimeter, but it is less than 7 centimeter in greater dimension and limited to kidney. This T1 is any tumor in greater dimension which is limited to kidney and it is less than 7 centimeter. T2, tumor which is more than or equal to 7 centimeter in greater dimension and it is limited to kidney. T3, tumor extends into major veins or it can invade adrenal gland or perinephric tissue, but not beyond the fascia. It has 3, T3A, T3B, and T3C. In T3A, the tumor invades adrenal gland or perinephric tissue, but not beyond gerotous fascia. In T3B, the tumor grossly extends into renal vein or vena cava that is below diaphragm. And T3C, it extends into vena cava above the diaphragm. T4, the tumor invades beyond the gerotous fascia. In T3, the tumor will not extend beyond the gerotous fascia. In T4, it extends beyond the gerotous fascia. Coming to lymph nodes, NX, the regional lymph nodes cannot be assessed. N0, there is no regional lymph node metastasis. N1, metastasis in a single regional lymph node. N2, metastasis in more than one regional lymph node. MS, distant metastasis cannot be assessed. M0, M for metastasis, M0, no distant metastasis. M1, distant metastasis. Staging, we are staging into stage 1, 2, 3, and 4. There is a follow-up for patient for underwent radical nephrectomy. The imaging follow-up for like if the patient has underwent radical nephrectomy for a localized renal cell carcinoma, if the patient is in the T1, we have to follow them with the chest radiograph yearly, and there is no need for abdominal CT. If the patient comes under T2, for T2 and T3, the follow-up is same. We have to follow the patient with chest radiography after the surgery, that is 3rd and 6 months, then every 6 months for 3 years, and then annually we have to follow. Abdominal CT, we have to do at 2nd and 5th year. The same for if the patient has underwent partial nephrectomy for a localized renal cell carcinoma, the imaging follow-up be like. For T1, there is no need to follow. There is no follow-up. For T2, chest radiography we have to do yearly. And abdominal CT we have to do every 2 years. And stage 3, every 6 months for 3 years. Then yearly. Abdominal CT is also same that every 6 months for 3 years and then yearly. Nephromatic scoring.
So, Jennifer, I'd like to add something here. So, we were going ahead with the surgery, right?
Yes, sir.
Like generally, when there is an oncology case, the dictum will be that they will diagnose it clinically, then they will bring it to us for staging or extension. And then for tissue diagnosis, we do biopsy. Why that was not done in this case?
This case we have done tissue biopsy, sir. Usually for renal cell carcinoma, after radical or partial nephrectomy, only we send the patient for imaging itself, we can diagnose the case. So after surgery, we are sending it for biopsy.
No, histopathological diagnosis, right? So why is it contraindicated in any way? Or is it like it's better to do nephrectomy and then
better to do nephrectomy and then send the patient for histopathology.
Is there any particular stages where you don't do the surgery and you have
T4 we will not do surgeries.
In such scenario, you will do the biopsy to get the HPV. So lesser stages, which is operable, you don't do biopsy. You just go for nephrectomy. So now you are going to talk about that. Okay, go ahead.
Nephromatic scoring. Renal nephromatic scoring was developed to categorize renal masses into low, intermediate, and high complexity. We are classifying into 3, that is low, intermediate, and high. It is based on cross-sectional imaging findings. The main purpose of nephromatic scoring is like patient decision making, patient counseling, and the main important part is surgical planning and follow-up and for academic reporting. The scoring is based on 5 basic radiological features of the mass. We have a mnemonic for this, renal, that is R for radius, E for exophytic or endophytic, N, nearness to the renal collecting system or renal sinus, A, anterior or posterior, L, location related to the renal course. Radius, it is measured in centimeter. We measure the maximum diameter in an axis. If it is less than or equal to 4 centimeter, we give 1 point. If it is more than 4 and it is less than 5, it's between 5 to 6, we give 2 points. If it is more than 7 or equal to 7, we give 3 points. Coming to exophytic or endophytic tumor, if it is more than or equal to 50% exophytic, we give 1 point. If it is less than 50% exophytic, we give 2 points. If it is 100% endophytic, we give 3 points. Nearness to the renal collecting system or renal sinus, we measure this in millimeter. This is the measure we take up from the shortest distance from the deepest point of the tumor. If the tumor is, the distance between the deepest portion of the tumor and the renal sinus, if it is more than or equal to 7 mm, we give 1 point. If it is more than 7, but it's more than 4, but it is less than 7, that is between 5 and 6, we give 2 points. If it is less than or equal to 4, we give 3 points. For anterior and or posterior location, there is no scoring. We use descriptor. We use A for anterior and P for posterior and X for neither. And location related to the renal poles. If we'll draw 2 polar lines in relation to the hilum. Superiorly, we'll draw 1 polar line in the superior part of the renal hilum, and inferiorly, we'll draw 1 polar line in the inferior part of the renal hilum. If the mass is completely below the inferior pole, or it is above the superior pole, we give 1 point. If mass crosses the polar line, we give 2 points. If more than 50% of mass crosses the polar line, or if it is entirely between the polar line, or if it crosses the axial midline, we give 3 points. And we use a suffix H, which is assigned if the mass touches the main renal artery or vein. This is a diagrammatic representation. The image 1, the mass, we are drawing 2 polar lines, superior and inferior polar line, and we are drawing a mid-axial line. If the mass is above the polar line or below the polar line, we give score 1. In the image 2, the mass crosses the polar line, but it is just touching the polar line, so we give score 2. In the image 3, in the mass A crosses the polar line more than 50%, and the mass B is located between the polar line. In the mass C is located mass C crosses the axial midline. So we give a score of 3 for this. Renal nephromatic in a table form. It's like renal, R for radius, it is measured in centimeter, E for exophytic or endophytic, N, nearness to the collecting system, it is measured in millimeter. N, we don't use, for A, we don't use score, we use descriptors, anterior or posterior, location relative to the polar lines.
Jennifer, Dr. Jennifer, can you explain the case which you have just reported? You are told that there is a nephromatic score of around 10 and it is given as 10x. Can you explain that to everyone using this section? What was the measurements you got?
Okay.
How did you arrive to that score?
In our case, the size of the lesion is 6.8. So it is less than 7 centimeter. So we gave a 0.2 point for this. And
usually when you say size, there will be 3 dimensions. There is AP, PR, and CC. So what are you considering?
The greatest dimension is 6.8. The size of our lesion is 6.8 into 6.5 into 4.7. The greatest dimension is 6.8. So we are taking that into consideration. So it is coming under, it is less than 7. So we are giving 2 points. And it is less than
Nisha, sorry to interrupt. Can you just show that image and then
okay.
explain? That will be more useful for others.
Okay.
Yes.
Okay.
Yes.
The size of the lesion is 6.8 centimeters. So we gave 2 points, and it is less than 50% exophytic. So we gave 2 points, and nearest to the collecting system, it is less than 4 mm. The deepest point of the tumor,
Yeah, continue, please.
Deepest point of the tumor and the collecting system is less than 4 mm. So we gave the 3 points. Location, we can, in axial plane, we have to look for location. So we can't give
Show it in the axial plane. Yeah.
We can't mark this is either anterior or posterior. So we have given neither X. Then mask, this mask, if you draw a polar line.
No, it's not like that. You mark it as X when the lesion crosses both anterior and posterior line. Okay. So that is why it is called X. Okay.
So if you draw a polar line, if you draw a 2 polar line, then the mass is 50 more than mid-axial line. The mass will cross the mid-axial line, and the more than 50% of mass is crossing the polar lines. So we give the 0.3. So we have arrived at a score of 10x, and which indicates it's a high complex.
So you have 2 criteria here. Like you have one criteria is the crossover of the pole, right? So the superior polar line is crossed more than 50%. Then the second thing is if the lesion touches the mid-axial line. So here it has both. So a score of how much was given? 3 again.
We gave total score. We gave it as 10x. 2. So we have 2, 2, 3, x 3. So we arrived at 10x.
Okay. Okay, go ahead. So now the lesion is high complex. So is there any slide showing that? Complexities?
Nephromatic score grading. The score of 4 to 6 indicate low complexity. Score of 7 to 9 indicate moderate complexity. Score of 10 to 12 indicate high complexity. Thank you.
Now I have a few questions here. So I think everyone else will also have that. Like why you are doing this nephrometric scoring before the surgery? What is the guideline here?
This nephrometric scoring is mainly used for urologists.
No. Explain in perspective with our case here. So you know already that the patient had undergone nephrectomy. So why the patient didn't get a nephron sparing surgery like partial nephrectomy or something like that?
Here the venous sign crossing the polar lines and the collecting system and the distance between the lesion is less than 4 mm. So the nephron, we can't do a nephron sparing surgery here, sir. So they have went for radical nephrectomy.
More than that, the important point here is the 4th parameter, where the lines are low. The lesion is crossing more than 50% of the interpolar lines, and it is touching the mid-axial line also. So that itself is a no for getting a, like you do the polar parts, you cut the top or bottom pole, like upper pole or the lower pole. You can't, if there is a lesion in the mid pole, there is no way you can do a nephron sparing surgery there. You have to remove the kidney entirely. So here the lesion is extending from the upper pole and it is going to the mid pole. That's the reason we have that they went for the nephrectomy. So this is where our role comes here. We have to give them a guidance whether or not to decide upon the complexity of the lesion using the nephrometric score. Okay. So lower scores, they can attempt a nephron sparing surgery. On the higher side, if the score is on the higher side, they have to go for radical nephrectomy. So that is the role here. Okay, Dr. Rashmi, anything you want to ask Dr. Jennifer? Or
Sadi sir also joined. Sir, are you there? Sadi sir, can you unmute yourself and a few comments on this? I think he has joined, but yeah, so that was a good presentation, Nisha. There is actually not much of a differential diagnosis, right, in this case? Because any enhancing tumor in elderly, we have to actually consider the possibility, unless proved otherwise, it is renal cell carcinoma. So is there any ways by which we can actually differentiate the different renal tumors? Just some points which helps us in differentiating?
If the renal tumors, it usually have calcifications. So if it is papillary renal cell carcinoma, it's a hypovascular tumor. Clear cell, which is a hypervascular tumor. And in oncocytoma and cases, it will have a central scarring will be there. It only in 1/3 of cases can have.
Jennifer, madam is asking whether you can differentiate benign versus malignant, because that's the reason we do the surgery, right? In whatever CECT you are doing, whether you can differentiate that. Is it possible?
Yes, you can differentiate. In renal one of renal angiomyelipoma, it will be like a fat containing lesion. In that.
Yeah, most of the time actually we have to actually differentiate it, because this happens when it's a small lesion, whether it's a renal cell carcinoma, early renal cell carcinoma or angiomyelipoma. How can you differentiate both?
Angiomyelipoma, it will be predominantly it's a fat containing lesion. Renal cell carcinoma, it can have fat, but it has a 30% of cases calcification will be there.
So if you see a lesion with both calcification and fat, what is the chance of being an AML or renal cell carcinoma?
Renal cell carcinoma.
Yes, very good. So it will be more favors a renal cell carcinoma rather than AML. So if you don't see fat in CT, is there any way that we can actually differentiate the AML from a small renal cell carcinoma? If you don't see fat,
then it can't be an angiomyelipoma.
Need not be. The lesion can have microscopic fat. So is there any way to differentiate that? Is there any other imaging modality?
But you can use MRI to see for a loss of signal in case.
Yes, that's how, like, if you are not sure, you can also always do a MR. And if you see a loss of signal in outer phase dual echo images, that is more favors angiomyelipoma rather than RCC. Because if you diagnose angiomyelipoma, what is the difference it makes in management?
It's a benign
carcinoma. The treatment, the management is surgery. While angiomyelipoma is a touch me not lesion. We not actually touch the lesion. So that's why imaging wise, it's very important to differentiate angiomyelipoma from renal cell carcinoma. But if you see a large heterogeneously enhancing lesion in elderly, we have to think of RCC only. Only thing is that if you see fat in it, and if you have a very small lesion, sometimes in CT, it is difficult to differentiate AML from RCC. So in those cases, we only do MR. Otherwise, like this case, like we diagnose renal cell carcinoma in CT and directly go for surgery. What do you know about transitional cell carcinoma of kidney? Is there any way to differentiate renal cell carcinoma?
It usually affects the collecting system. The shape of the kidney will not be changed. The size will be enlarged, but the shape will not. The shape of the kidney will remain. The bean shape will be maintained. Yeah. And it's a hypovascular tumor.
Yes. So RCCs will always be a ball type of lesion, while TCC will be a bean type of lesion. That's like how we differentiate the two types of lesions in kidney. And RCC will always be hypervascular, while TCC will be hypervascular. And you can actually, if the renal pelvis is involved, if it's epicentered in the renal pelvis extending into the callus, it will be more favoring a TCC. And TCCs, most of the time, it will be multifocal, because you should always look for the involvement of ureter, bladder, etc. in TCC, while RCC, it will be like a ball type in the periphery. That's how you mainly differentiate both. Yeah, that was the good presentation, Nisha. I think that's all from my side. I don't know whether Sadi sir will be joining or not.
He's online, madam. I don't know. He might not be able
Sadi sir, are you there? Any comments from your side? I think maybe he's busy in actually he's in this institute, so maybe that's what. I think that's all, Nisha. Arif, anything from your side?
I would like to add one point here, like since Madam has asked about MRI, there is a way, there are certain literature saying that you can actually differentiate two types of renal cell carcinoma using MRI.
Yes.
That is between the papillary type and the other variant. That is one will be hyperintense on MRI, the other T2 images, specifically T2 images, one will be hyperintense and the other one will be hypointense. So that is one way you can determine between two entities. So this might be asked in an exam by someone. Example
Papillary will be T2 hypointence and clear cell will be
hyperintense.
Yes.
So that is one way of identifying the histological type. You can predict to a certain extent, not accurately, but to some extent. Yes. So I think we can move ahead with spotters, right?
Okay. Yes.
If everybody is okay with that. So I'll share my screen now.
Yeah.
So guys, I've added 10 spotters here. I'm quite the spotter guy. I like to do spotters. As if you have visited my channel, you would have seen that already. So we have 10 spotters, which will be related to GUT only, exclusively GUT topic. And you will be given a short period because we have a limited time, only 10 more minutes is there. So we'll finish it fast. There is no gap. The question will come, then next slide will be the answers. So you can type your answers in the chat box if you want, or you can just write it down. That's all. So I'm starting it. So can you see this screen, everyone?
Yes, yes.
Jennifer, are you able to see this?
Hi, sir.
Okay, so we'll go ahead. So this is me. And this is the first spotter. So I want you to identify the study and what is the finding here. So I think Jennifer can try answering it if you want. So shall I move ahead with the answer? I think few of them have answered.
I think they have all, in the chat box, they have actually told it's IVP that we all know. Nobody...
No, I want you to answer the finding. There is a very interesting finding here. Yeah, one of them have answered it. Yeah. So now I'll go to the answer. So this is something called nephroptosis. So nephroptosis is otherwise called as mobile kidney or hypermobile kidney because kidneys are mobile. But in this case, it is hypermobile kidney. We call it as floating kidney as well. So how you assess it is you have to make the patient ambulant. That you can't assess it in a static modality. You need a mobile modality like pyelogram. You can make the patient lie down. You can make the patient stand up. Or you have to do a supine and stand-up position, ultrasound, Doppler, something like that. So this is important because some patients, this might be the cause for like a long-standing abdominal pain, especially in females. So this is nephroptosis. So in the image, you can see here is in the supine phase, you can see the right kidney is almost in its natural position, a little bit lower if you compare to the left, which is normal, and it has gone down on standing up. It has gone down beyond almost into the lumbosacral region, to the pelvis. The lower pole is almost reaching the pelvis. So the way to assess this is like the lower pole in the supine position and the lower pole in the prone position or lying down position. Means standing up position. There should be a 5 centimeter difference will be there. So then you can say it is having the nephroptosis. So the management is nephropexy. That's a surgery where you anchor the kidney to the facial planes. So next quarter is this one. You can try answering this. There are multiple slides are there. Please look carefully and answer. only one person has answered so far. I think everybody is typing the findings here. So I'll move ahead to the answer slide. So this is, as a few of you have told here, it is MRKH, Mayer-Rokitansky cluster Hauser syndrome. And this slide has been just kept to show you different. There are two types of MRKH. It is type A and type B. So type A will be classical. There will be only Mullerian aplasia absent. So Mullerian aplasia means you will be having a part of the uterus absent, and that's it. So type B will be Mullerian aplasia with renal anomalies, ovarian and fallopian tube pathologies. So in our case here, there is absent right kidney, and you have a Mullerian anomaly. There is no uterus seen, and there is no fallopian tubes as well. Ovaries are seen actually in this case. So this is a type, this is a type B MRKH. Okay. So next. So this is actually a serendipitous spotter, because we had discussed now that I think most of you will answer it. So most of you have written the single diagnosis. I want it to be, it is a spectrum of a disease. This is actually a finding of a spectrum. Yes. So yes, this is bilateral renal angiomyelipomas. So this is a different case, and this is a different case. As you can see here, in this case, there is a large angiomyelipoma of the low pole. Then we have multiple renal lesions on the left side as well. So this actually mimics a hypervascular lesion here. So, but when you see it bilaterally, it is usually tuberous sclerosis related. So this is a case of tuberous sclerosis where you have bilateral large renal angiomyelipomas. So the entire kidney morphology is altered by the angiomyelipomas. So next quarter. This is a relatively simple one. I think most of you can answer this. Yes, this is emphysematous pyelonephritis. I think there is no need for much explanation here. This is a CT image of the same patient. So here, one thing I wanted to discuss with you guys are there are types are there, type 1 and type 2. It is based on the severity of involvement of renal parenchyma. Nothing else matters actually. So if the more than 50% of the renal parenchyma is affected, that indicates a severity, high severity, and there is a high chance that patient will have like high morbidity, mortality for that condition. So greater than 1/3 renal parenchymal destruction with absent collections is considered as type 1. So as you can see here, there is a large perinephric collection also in this case, but then also it is grouped under type 1 because involvement of more than 50% of the renal parenchyma, it directly goes to type 1, even with or without collection. So remember that. So type 2 is lesser amount of cortical destruction. That's all. So next quarter, again a simple one. So few of you have answered it as CHPS and other few have answered it correctly. So this is actually pseudo kidney signs. You can see this is the normal kidney here and this is like a pseudo kidney sign. So this happens in intussusception. Yes, it is intussuscepted bowel, the pseudo kidney sign. I just wanted to show you that how it resembles a kidney. Okay, going ahead to the next spotter. So I think I'll put the answer now. So as you can see here, there is a cystic lesion on the superior surface of the and anterior surface of the bladder dome. So this is actually a urachal remnant cyst, and the correct answer would be infected urachal cyst. Why? Actually, you can see the cyst content is a little bit relatively hyperattenuating, and there is a significant pericystic fat stranding is there even in the anterior abdominal wall side as well as in the peritoneal side. So when you see this, it's usually infected, and it's very quietly common with large urachal cysts. Okay, next part. I know it is a very short time, but whenever you are writing your spotters, remember to write it in full. So this is actually a vesico-cervical fistula. So this is actually like an iatrogenic thing where a patient undergoes LSCS surgery, and after that he or she develops this fistula's communication between the posterior wall of urinary bladder with the your cervix, uterine cervix, or the lower uterine segment. So this is an axial image of the same. So this is a vesico-cervical fistula. Okay, you can see here the communication. This is actually an oblique coronal to show you the track, communicating track. So next quarter. Yeah, already a few of you have answered it. So this is actually GU infection by schistosomiasis. So in this, I just wanted to add some points here because most of us will not be reading this. And there will be extensive bladder calcification, and it is actually seen in the late stage of schistosomiasis. And the particular pathogen involved is Schistosomia hematobium. So this is one. Wherever it is endemic, can cause these kind of calcification, and this is interesting. So what are these calcifications actually? These calcifications are roughly around 100,000 eggs of the pathogen, that is the parasite. So there is not a certain number limit is not there, but if it is more than 160 HU, it will see it as calcification. And generally, the calcification starts at the bladder base towards the trigone, and if treated properly, the entire bladder calcification will go off because these things will keep on excreting in urine and it will go out. So around 2 lakh eggs excreted per day, you will get it cleared in a few months. That's what literature says. So next photo. a simple straightforward spotter. Yes. This is posterior urethral valve. The sign is called keyhole sign, and this is an antenatal ultrasound, and that's it. There's nothing much to explain it. It's a straightforward spotter. Towards the last quarter of the session, what is the study and what is the finding here? Yeah, few of you have answered already. So it's a rectovesical fistula, and the study is actually MCU. Okay. So I think that's the end of the session. Thank you, guys. Hopefully it was in.
Yeah, it was very useful.
Really, it was really wonderful. The spotters was really very good. I was just seeing all the spotters, and you made
Thank
it.
you, madam.
It was a very good discussion also. It was really, really wonderful, Dr. Arif. I'm meeting you for the first time. I'm very happy that you have presented the spotters and the case discussion. It went on so well. Really, all the residents should attend, I feel, because it is all exam cases. We didn't have such cases and discussion or spotters review like this for us. It's a good time that all the students should take this as a challenge and come first in their examination, I feel, because we are showing such wonderful cases and spotters. Thank you so much, Dr. Arif, for your wonderful presentation. And thank you, Nisha. You did well.
Okay.
Yeah.
So anyone? Okay.
Yeah,
Okay.
Arif, actually, there is a question. They were asking, what is your YouTube channel name?
Okay. It's I'll just type it here. It's the interventionist.
Yeah, the interventionist, right?
Yes.
Yeah.
I think it is not coming when you're typing it. Chat box. Yeah. You can tap. Yeah.
Okay, ma'am.
Yeah. So everybody, I think now you have more followers in your YouTube channel.
Yes, hopefully. Thank you.
Okay, that's good.
Okay.
So it was a good presentation. Dr. Nisha, thank you for that, especially the nephrometric scoring and all, and how did you arrive and what is the importance and significance of that. It was very useful. So thank you, Nisha, and thank you, Arif, for the guidance and as well as the wonderful spotters that all are exam cases. So thank you for that, Dr. Arif. I think Sadhi sir, I think that he is busy in his workplace, so he has actually left. Thank you, Gomadi ma'am, once again. So she has been there always for us, supporting us and conducting this Kerala IRA academic sessions for the residents. It is actually very useful for that. Actually, all the residents must actually take use of this. Everybody should attend it, and we also have this in the YouTube channel of Kerala IRA also. You can always view this at any time, so it will be uploaded in YouTube. So thank you, Gomadi ma'am. Thank you, Venus sir.
Madam, if I have some time, I would like to add something.
Yeah. Sure.
On behalf of Radiology Department of Sri Mugambika, we all thank you for giving us an opportunity to present in IRI conference right now. I think Vinod sir and Satish Prabhu sir came in between, and they left because they're busy with work. And thank you, madam, once again, Gomadi madam and Shinoi sir and Rijo sir. And if I had missed anyone's name, sorry, because I'm not that familiar with the IRA right now. I know everyone here and there. I know Rashmi madam personally and a few other members. Other than that, that's it. Thank you. And thank you.
Do join us for the sessions also, Arif.
Yes, we'll try, madam. We'll try.
Yeah.
Sure.
No, you now become IRA faculty of Kerala, so that we'll be contacting you, and I'll be in touch with you for many other programs also. Okay.
Thank you.
Thank you, Gomadi ma'am. I told. Thank you, Venus sir. Thank you, Ramesh sir. Today, actually, he's not able to join, but he is the main person behind the coordination of all these academic sessions. Thank you, Rijo sir, and thank you, Venus sir, and thank you all the attendees who have attended the session. So we'll be continuing Genitourinary GUT this month. So this Saturday we have interventional radiology and renal vascular. That's the topic by Dr. Manish from KIMS. So do join us the coming Saturday. So see you all next Saturday. Thank you once again. And thank you, Soumya. I missed that because she's the person who is, thank you for the smooth contact without any technical glitches. Thank you, Soumya. As always, she's been very cooperative. So thank you, Soumya, and thank you, MedPiper team. Thank you so much. So, Madam, let's wind up the session.
Yeah, we can wind up.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am.
Thank you, madam. Thank you. Bye.